Imagine walking into a mailbox. You sort through a stack of letters, and there it is, a crisp white envelope from your local hospital. A few weeks ago, you had a medical scan during one of the most stressful stretches of your life. You're waiting for the result, losing sleep, wondering what the doctor might find. Then the scan came back clear. No cancer, no worst-case scenario, just relief. So you open the envelope expecting some routine statement, and instead, you see the amount billed to your insurance company, $70,000 for a single 45-minute scan. And what makes that number so shocking is not just the size of it, it is the fact that you have no real framework for how it was calculated. You have your house insurance, you did what you were supposed to do. You pay your premiums, your employer pays their share, you carry the little plastic part in your wallet, and still you're standing there staring at a number that makes no sense. In almost any other parts of the economy, a transaction that large would come with like months of negotiations. You have contracts, lawyers, and absolute clarity on what you are actually purchasing. In the US healthcare, the number just arrives, and then you start asking the most basic question: what exactly did I just buy? Welcome to Summerlands, a podcast about how healthcare really works. Not just a company, not just the news, but the money, the incentives, the institutions, and the power underneath it. I'm your host, Eva. And I'm making this show because the more I learn about healthcare, the more convinced I am that if we want to talk intelligently about medicine, innovation, patient, or policy, we have to understand the machine underneath the headlines. And there's no better place to start than with one of the biggest paradoxes in American life. How did Americans build the most expensive healthcare system in the world? In 2024, the United States spent $5.3 trillion on healthcare. This works out to about $15,474 for every single man, woman, and child in the country. I can't even conceptualize $5.3 trillion. It just sounds like a fake number you make up when you are playing Monopoly or something. The easiest way to grasp it, I think it is by looking at the broader economy. That spending consumes 18% the entire US GDP, and if we just look at the number, it would be larger than the entire GDP of Japan. It would be larger than the economy of Germany. And yet, US life expectancy in 2024 was 79 years. The uninsured rate was 8%. The US still tries peer countries on several broader health outcome measures. And here's the paradox. America has some of the best hospitals in the world, majority of the most advanced medicines in the world, lots of the most important biomedical innovation in the world, and also the most expensive healthcare system in the world. So what happened? Today, I want to reverse engineer the machine to understand what American actually built financially, legally, and politically that produces this outcome year after year. Because a system this large, this expensive, and this durable didn't happen by accident. So why it is so expensive? To navigate this, I want to give you a very simple equation to hold in your mind for the next 30 minutes or so. It's just basic economics. Spending equals price multiplied by quantity. Think about it in terms of buying groceries for your family. If your household's grocery bill is widely higher than everyone else on your street, you have to ask a foundation question. Is the bill higher because your family is eating twice as much food as the neighbors? That's the quantity. Or it is because the price. You are walking into a supermarket and paying $50 for a single apple? Try to think about the US healthcare. Are Americans simply consume dramatically more care? or is each transaction inside the system unusually expensive? And if it is a $50 apple, we need to know who is setting the price, who is paying it, and why no one can seem to stop it. By the end of this episode, you are going to understand the invisible structure drivers of this price machine. And you will see why, historically, whenever politicians promise to quote-unquote fix the system, we usually just end up adding another layer of bureaucratic drywall over a cracking foundation. So if we use that grocery framework, the most logical starting point is the quantity variable. Do Americans just consume dramatically more healthcare than anyone else on Earth? To answer that, we need to look in the international mirror. And the best mirror we have is the Organization for Economic Cooperation and Development, the OECD. They adjust the data for purchasing power parity and compare health systems across wealthy countries. On that basis, the US spends about $14,880 per person to healthcare. Which sounds high, but how does that actually stack up against the economic peers? Like places, the UK, France, Germany, Japan, it's roughly 2.5 times the OECD average. Not 20% higher, not 50%, 2.5 times higher. So let's go back to the quantity. Are Americans simply using 2.5 times more healthcare? When you actually look at the volume of care provided, the whole narrative just falls apart. Let's look at hospital beds, which is, the costly fundamental metric for healthcare capacity. The US actually has significantly fewer hospital beds per capita than its peer nations. The US is at about 2.8 beds per 1,000 people. The OECD average is about 4.3. That is not what we would expect if the US was simply over-consuming hospital care. And it is not just beds. Americans are not going to the hospital twice as much. The admission rates are comparable or sometimes even lower. And we look at physician visits. The average American actually sees a physician fewer times per year than the average citizen in other health income nations. That matters, because if the spending is 2.5 times higher, but the quantity is nowhere near that, then the math dictates something pretty terrifying about the other side of the equation, the price. This is exactly where the best comparative research points. A major JAMA comparison found that utilization across high-income countries are often broadly similar, while prices of labor, goods, pharmaceuticals, and administration appear to be the main drivers of the US spending gap. We are, in fact, buying the 50. But we have to carefully define what price actually means in healthcare economics here. If you are picturing a medical bill, you might assume price refers to the raw cost of the physical materials, like the literal cost of the bandage, an IV bag, or sterile syringe. But I mean the market of an IV bag is absurd in hospitals, but that alone couldn't account for trillions of dollars. When economists say health price levels are higher, they are capturing a much broader ecosystem. The price includes the negotiated rates for complex procedures, absolutely, but it also bakes in the massive invisible administrative overhead required to keep the lights on, the paperwork. And crucially, it includes the literal wages and compensation of each single human being working within the system. Let's pull the threads on wages. I saw the OECD data on that. The data shows our US general practitioners makes on average about $218,000 a year, and specialists average around $316,000 We have to acknowledge that these are highly trained professionals, right? They're often carrying crushing amounts of medical school data, and they're performing critical life-saving work. Nobody is sitting here saying a neurosurgeon shouldn't be highly compensated, but from a purely comparable microeconomic standpoint, those compensation levels dramatically exceed the averages in other G7 countries. A doctor in the UK or France makes a fraction of that, so when a patient pays a medical bill in America, a significant portion of that higher price is directly funding higher labor costs across the entire medical sector. Let's go back to the grocery example. In any other or in any normal market, if a grocery store tries to charge me $50 for an apple, I laugh, I walk out the stores, and I walk to the supermarket down the street. The overpriced store goes out of business. So how does the US healthcare system enforce prices that high without the entire market collapsing under its own weight? But to understand how a market sustains artificially higher price without collapsing, you have to look at the buyers. You have to understand who is actually paying the $50 and how totally insulated they are from the pain of that transaction. Which means we need to talk about the historical past dependence of US healthcare financing. We have to look at the architecture of that patchwork. How did we accidentally build a system that guarantees someone will always pay the $50? Because to a lot of listeners, getting health insurance through a job feels completely normal. You get a job, you get health benefits, it's just how things are done, and globally, it's pretty unusual. Historically, it was never the product of one clean, rational design. It emerged through a very specific sequence of political and economic decisions. Let's go back to the 1940s. World War II is underway. The US economy is fully mobilized for war production. Factories are booming, labor is tight, and the Roosevelt administration is deeply worried about inflation. So the government imposed strict wage and price freezes. They essentially tell corporate Americans, you are legally forbidden from raising the hourly wages of your worker. But employers still need workers, so they look at another way to attract labor. They offer them something that has value but isn't technically a wage. So employers start offering fringe benefits. They say, hey, come work for my shipyard, and I will pay for your family's medical care. In other words, employer-sponsored health insurance begins to expand not because policymakers sit down and decided this was the best way to finance care, because it worked as a workaround inside a wartime economy. So it starts as this temporary wartime loophole. How does it become the permanent bedrock of a $5.3 trillion economy? Well, the tipping point happened in 1954. In 1954, the IRS clarified that employee contribution for employee health insurance would be excluded from federal income and payroll taxes. I want to make sure you really grasp the magnitude of this. Let's do an example. If my boss wants to reward my hard work and gives me a $5,000 cash bonus, the government steps in and taxes a huge chunk of that. I take home maybe $3,000, but if my boss takes that exact same $5,000 and use it to buy me a gold tier health insurance plan, neither of us pays a single cent of tax on it. This is the mechanism, and the scale of that hidden subsidy is truly mind-boggling. If you look at US Department of Treasury data today, the exclusion of employee contributions for medical insurance premiums is constantly one of the single largest tax expenditure in the entire country. The projections for fiscal year 2026 show that this exclusion costs the federal government hundreds of billions of dollars a year in foregone tax revenue. And that historical accident creates a profound economic distortion called the loss of price sensitivity. This actually answered to the $50 apple. In a normal functioning market, the consumer directly feels the financial pain of a high price and the refusal to pay forces the seller to lower the price. But in US healthcare, the employer gets a massive tax break to buy the insurance. The insurance company pays the hospital for the procedure, and the employee, the actual patient, never sees the true monthly premium deducted from their paycheck. They only see their relatively small biweekly contribution when the true underlying cost of the transaction is legally hidden from the person receiving the service. The downward pressure on prices completely evaporates. The hospital can charge the insurance company the $50. The insurance company passes the cost to the employer in the form of higher premiums next year, and employer absorbs it by quietly suppressing employee wages. It's just an invisible cycle. And once you zoom out, you see that employer insurance is only one layer of that large cake. According to the Census Bureau, about 92% of Americans had some form of insurance in 2024, leaving 8% uninsured. But that insured population is not one coherent block. It is a layered system. That 1940s employer-based model is still the dominant layer, covering about 53.8% of the population, and Medicare, primarily for those 65 or older, covering 19.1%. Medicaid, designed for low-income individuals, covering 17.6%. And you have the ACA, Affordable Care Act marketplaces, which hit 21.1 million in 2024. So when people talk about the US healthcare system, they often imagine one national system. It is not what we have. What we have is multiple financing systems operating side by side, often inside the exact same hospitals and clinics, same building, different payers, different rules, different reimbursement logic, and different patient experience. That fragmentation is one of the defining features of the US healthcare system. And it matters because fragmentation creates complexity, and complexity creates costs. So let's bring this down to the household level. For a family with employer-sponsored insurance, the average annual premium in 2024 reached $25,572. Of that, works directly contributed about $6,296, while employers covered the rest, and the employer contribution is not free money. From the perspective of labor economics, total compensation is in one bucket. Salary, benefits, retirement match, bonus, they all come out of the same pool. So when health insurance premiums keep raising, part of what happens is that wage growth gets squeezed. Basically, your raise went to the insurer. And that creates one of the most frustrating features of the system from the patient's point of view. You may be paying thousands of dollars a year for coverage. Your employer may be paying far more. And yet, when you actually try to use the system, you still run into deductibles, co-pays, co-insurance, surprise bills, and coverage restrictions. You are paying a lot to have insurance, and then paying again when you need care. Let me use one analog here to help the listener help you to reconceptualize this fragmented multi-payer system. Imagine you need a new television, you work into a giant electronic store, you find a TV you like, you pick up the box, you walk up to the checkout. Okay, now the price on the TV on the tag is $500. But in the US healthcare system, the price of that exact same TV depends entirely on your demographic identity and who your boss is. For example, I walk up to the cashier asks for my ID. If I am like 66 years old, I pull out my Medicare card, the cashier checks the massive federal binder and says, the government has fixed the price for you at $300. Have a nice day. Then the next person walks up. He's low income, he has Medicaid, the cashier checks the state binder. The state's paying for this TV. But the electronic stores still need to make a profit to keep the lights on. They couldn't survive just selling it at a discount. So the third person walks up. She has private insurance through a massive tech company that negotiates rapidly. She pays $600, and the fourth person has insurance through a small local bakery with terrible bargaining power. So he pays $1,200 for the exact same TV. And finally, the fifth person walks up. She's part of the 8% who are uninsured. She has absolutely no institutional backing. The cashier looks at her and demands the absolute maximum charge master list price, $4,000. And the strangest part is absolutely no one, not the consumer, not the cashier, not the store manager, knows what the exact final price is going to be until they swap the specific identity card, run through a clearinghouse, and wait for an algorithm to decide the allowable charge. It is a system of price setting without the central setter. It is thousands of different payers, commercial insurers, self-funded employers, government programs, all working into thousands of different hospitals trying to negotiate blindfolded. And once you build a system like that, one consequence becomes most inevitable. Prices stop being transparent and start being negotiated. At this point, the next question is really obvious. If the architecture is fragmented, who actually has the power to name the price? So, this is where the story gets more concrete. If fragmentation is the architecture, then the price machine is what the architecture and the two biggest outputs of that machine are explosion of administrative costs and consolidated market power for the hospitals. This is where a huge amount of money goes. Let's start with administration. Because when you build a system, when thousands of payers are negotiating with thousands of providers under thousands of different rules, you don't just get complexity. You get overhead, you get delay, you get coding disputes, prior authorization, you get appeals, you get billing of departments on one side and claims departments on the other. And all of that costs money, a lot of money. The OECD's narrow framework estimates administrative costs at about 8% of US health spending. When your denominator is 5.3 trillion, 8% is massive. It's over 800 per person, roughly 5 times than the G7 average. The US healthcare system is not just buying here. It is buying billing. This is not a side fact. It is part of the system. Hospitals employ armies of coders, compliance staff, billing specialists, and revenue cycle teams, while insurers employ their own armies of claims reviewers, utilization managers, medical directors, and software system designed to scrutinize those claims. It is an administrative arms race, and the cost of that arms race got folded back into the price of care. But administration is only part of the story. Let's look at the other major consequences of this fragmentation. Market power. We need to look at the other side of the negotiation table. We already have the fragmented buyers, the payers, but what of the sellers? What about the hospitals? This is where we see the most aggressive driver of actual price. If we go back to the CMS National Health Expenditure data, hospital spending is the single largest bucket of that 5.3 trillion. We spend 1.6 trillion just on hospital care. And over the last few decades, the landscapes of who owns those hospitals are radically changing. We have seen a wave of hospital consolidation. Independent community hospitals have just been bought up. You now have these massive mega systems that dominate entire metropolitan regions. And when a single corporate hospital system acquires the majority of the acute care beds, the specialized oncology clinics, and the level 1 trauma center in a given city, the nature of the negotiation between insurer and hospital changes. It stops looking like a competitive market. It starts looking like leverage. This is the most highest contest battlegrounds in health policy right now. Let's start with the data that critics point to. We are looking at the findings from the RAND Corporation's Hospital Price Transparency Initiative. They look at what private insurers, the employee-sponsored plans, were actually paying hospitals, and they compare it to what Medicare pays for the exact same services at the exact same hospitals. The RAND findings are really striking. In 2022, they found that private insurers paid hospitals on average 254% of the Medicare rates. And furthermore, if we look at reviews conducted by the Government Accountability Office, the GAO, their synthesis of the broader economic literature generally points in one single direction. Hospital consolidation generally increases prices and spending, while quality often changes little. The economic logic is just straightforward monopoly dynamics. If you are the only major provider system in town, you have the leverage to demand the rates. However, the hospitals passionately dispute that narrative. They argue that they are the victims of the fraud system, not the violence. And their perspectives is absolutely essential to understand the full financial ecosystems. The American Hospital Association, the AHA, argued that the RAND study, for example, is methodological skewed and highly incomplete. They note that the claims data used represents less than 2% of total hospital spending across the country. And also, AHA argues that the government programs, specifically Medicare and Medicaid, systematically underpaying hospitals. They argue that the government reimbursement rates simply don't cover the actual fundamental costs of providing the care. If you read the reports from MedPAC, which is the official Medicare Payment Advisory Commission, they frequently document that overall Medicare margins for hospitals can be negative. Hospitals assert that if the government legally forces them to take a financial loss on a massive percentage of their patients, they have absolutely no choice but to forcefully negotiate much higher rates with commercial private insurance. They have to subsidize the care just to keep their trauma centers open and their nurses paid. That nuance matters. But the broader pattern is still hard to avoid. When hospitals consolidate, bargaining power raises, when bargaining power raises, private price raise, and then premium raise. And when premium raise, employers and employees absorb the cost. The price machine just keeps in motion and the consumer takes a hit. Which brings us to an incredibly timely topic and a major pivot in our understanding of where the money goes. Because when you talk to a person on the street or you watch a political debate and you ask why the US healthcare is so incredibly expensive, they always point the finger at one specific target, the pharmacy counter. They point to the pharmaceutical industry and expensive blockbuster drugs. We see the viral headlines about a new cancer pill that costs $15,000 a month, or the price of insulin. It is deeply emotional and it is highly visible because the patient actually physically buys the drug at a counter. Are drug companies the main reason US healthcare is so expensive? It absolutely matters. But the micro data reveals a much more nuanced story about where the trillion-dollar flow of money is actually going. We really need a serious reality check on the scale of pharmaceutical spending. If we go back to our official CMS scoreboard for 2024, retail prescription drugs accounted for about $467 billion. It is a massive sum of money, but compared to 1.63 trillion hospital care, as a slice of a total 5.3 trillion pie, retail prescription drugs account for only about 9% of total health spending. If Congress, for example, passes a law tomorrow that magically made every single prescription drugs absolutely free, $0 at the pharmacy counter, we would still have a system that costs about $5 trillion. While US per capita pharmaceutical spending is undeniably higher than the OECD average, the outpatient clinics, the administrative bloat, and the massive hospital sectors that we just spent the last 30 minutes discussing are actually the vast larger drivers of the spending gap between the US and its international peers. But we can't ignore the drug pricing space because it introduces another critical, highly secretive layer of the price machine, the middleman. We're going to do a massive deep dive on this specific topic in a future episode, but we absolutely have to preview it here to understand the full architecture. We have to talk about the middlemen as pharmacy benefit managers, or PBMs. When you walk up to a pharmacy counter and hand the pharmacist your insurance card, the entity operating in the crowd deciding instantly whether your specific drug is covered, what your copay will be, and how much the pharmacy will actually get reimbursed is usually a PBM. They sit right in the middle of the transaction, and according to the recent highly critical finding released by the FTC, this market is breathtakingly concentrated. The data shows that the big three PBMs manage about 80% of all prescriptions filled in the United States. They sit between the drug manufacturer, the health insurance company, and the local pharmacy. Extracting a slice of values from a single transaction through complex rebates and fees, it adds an entirely new layer of ambiguance of what the true prices a drug actually is. But to be perfectly fair to the pharmaceutical ecosystem, there's another side of the drug pricing argument, that is the innovation narrative. The industry argues that these high prices serve a vital global purposes. The core defense of high US drug prices is the argument that the American consumer is effectively subsidizing global medical research and development. In our future episode, we're gonna do a deep dive in GLP-1 drug, how this 41-year-old drug development looks like. Alright, so we've established the mechanics of the machine. We're spending $5.3 trillion. We're paying the highest prices for the $50 apple. We have a massive self-perpetuating administrative layer and strong vinyl pricing power. We're subsidizing global drug innovation. I want to transit to the ultimate question, the ROI. What is the return on investment for you, listener, for all US taxpayer? What are we getting for 18% of our GDP? How healthy are we actually getting for all this money? The true return on investment, and this is where the data becomes quite sobering and forces us to look beyond the finances and into public health. Because if you look at the ultimate final metric of a health system, life expectancy, the United States underperform its peers. According to the CDC data for 2024, US life expectancy stands at 79 years. It lags more than 4 years behind the average of our peer nations in the OECD. We are paying 2.5 times more money, but on average, Americans live 4 years less. In fact, when we look at the clinical excellence of the acute care system, it's phenomenal. If you are severely ill, the US system is absolutely best place in the world to be. The OECD data clearly shows that the US actually perform better than international average on critical metrics like 30-day mortality after severe stroke or an acute heartbreak. Our intensive care units rapidly respond surgery interventions, our specialized oncology wards are world-class. So the hospitals are doing their job when you show up bleeding at your doors. But where does the system fail? It fails spectacularly in what happens before you ever reach your doors. If we look at the OECD snapshot for the US, the preventable mortality rate is staggering. The US rate is 238 per 100,000 people, compared to the OECD average of just 158. And look at avoidable hospital admissions. These are admissions for chronic conditions or severe diabetic complications that should be easily managed with routine checkups in a regular doctor office. This signals a massive structural failure in basic primary care and continuous chronic disease management. John Hopkins looked at the life expectancy gap between the US and England and found that a large share came from causes like only partly because healthcare delivered it itself. Cardiovascular disease explained 57% of the gap, drug overdose explained 32%, firearms explain 20%, and motor vehicles crashes or take account for another 17%. Now I know you are doing the mental health in your head right now and say, well, 57 plus 32 plus 40 plus 17, it is more than 100%. This is because there is statistically contribution to a differential gap, and the US actually performs better than the UK on some other metrics like mortality rates for certain specific cancers, which push the baseline back on the other way. This is revealing because it means part of the reason the US underperforms is not that it lacks advanced medicines, it is the health outcomes that are shaped by a broader social environment. Chronic disease, prevention, violence, addiction, public health, and inequality. This is a tragedy of the US healthcare system. We can build the best trauma center on earth. We can invent the most advanced robotic surgery arms. But if a patient comes through the sliding doors with a gunshot wound or severe opioid overdose, or an advanced heart attack caused by 30 years old food insecurity, and untreated care because they couldn't afford a primary care doctor, and the hospital is just treating the end-age symptom of a broken society. We have heavily over-indexed on financing the acute end-age interventions, but we have heavily under-indexed on public health, primary care, and social support. That's why best hospitals and highest spending don't automatically translate into best outcomes. So, as I wrap up this deep journey through the architecture of US healthcare, here's the summary for you to take away. The United States health system is unique, vastly expensive, and it is not expensive primarily because Americans use an extraordinary amount of medical care compared to the rest of the world. It is expensive because through historical accidents and tax policies, we built a structurally fragmented multi-payer financing architecture. This architecture is effectively a machine designed to generate high prices. It funds a massive, more than $800 billion administrative layer, just manages on friction. It moves consumer price sensitivity and it automatically reverts consolidated market power, allowing hospitals and middlemen to dictate terms. It is a $50 apple wrapped in 3 layers of paperwork, negotiated blindly by 4 different middlemen, and subsidized by a tax loophole from 1954. In our upcoming episodes, we're going to explore the deliberate manufacturer complexity of this system. We'll look at the paradox that our health insurance actually drives up the cost of your care. We will pull back the curtain on the corporate powerhouses that run modern hospital mega systems. We will finally confront those invisible middlemen, the pharmacy benefit managers, who control your access at the pharmacy counter. I promise you, understanding the price tag was just Act 1. Thanks for listening to Summer Lens. If this episode helped you see this system more clearly, share it with someone who wants to understand healthcare beyond the headlines. See you next time.